Hi, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio on this chilly but sunny spring morning in April. We are delighted to be back with you. It's been over a year since we've been doing this program, and one of our initial first guests that was ever on it with us was Rachael Liesman, talking about how we do testing. And today, we're going to talk about testing. Everybody's talking about vaccines, including us, but we ought to still talk about testing, because you know what? You got to still test if you're going to understand how we're doing with this disease. Joining Rachael will be one of our partners from Microbiology, Marissa Larson, who is a medical lab scientist. Welcome, Dr. Larson. We are so happy to have you here. And of course, we have Hawkeye.
Hi. Yes.
How are we?
We're good. The authority of the good doctor of everything that's in the micro and molecular labs really keeps our diagnostic test ordering on the top shelf there for sure. So a lot of help though on a daily basis when we're seeing especially complex patients. So today our numbers are still okay, holding steady. We thought they were maybe climbing, but kind of have gone back down to that 10 range. 10 or lower is always good. Obviously 0 is the best, but 10 active infections with 6 in the ICU, 3 on the ventilator, and 8 in that recovery period. So 18 total, under 20, which is not bad.
Darn good.
I know we were getting concerned with the general number of cases in the country and also here around the Kansas City community as well. Hays has 4 patients as well, 3 active and 1 in that recovery phase. So they're kind of holding steady as well.
So it is better. And some big news over the yesterday from the New England Journal of Medicine.
Yeah.
One thing, the vaccine based upon some of the V-Safe data, safe in pregnancy.
Safe in pregnancy.
So let's be sure. A, it doesn't cause sterility. B, it doesn't cause abortions. C, it is keep mom and baby safe because those antibodies do appear
and you
to get
take that
into
with exactly, with the other studies showing that you can actually have antibody transfer to baby, just like with other vaccination as well, so helping to keep babies safe as well. And we should say that, all of the obstetrics medical societies, ACOG in particular, and the Society for Maternal and Fetal Medicine would all recommend and said if you were pregnant and you were offered the vaccine to get it, obviously talk with your provider, but that offers more concrete data for that.
Second thing that was kind of a big deal was the J&J vaccine, because they looked at it and as a one-shot regimen. The J&J's had some bruises, right? Had some clots, but very, very few really. And when you looked at it against the South African variant, still had pretty darn good activity.
Yeah.
Against South African variant in South Africa, so also good news, I think. So a couple of good things out there on the vaccine front, and remember, you want to live long and prosper. V for vaccination. I know I'm going to go back to that all the time, people.
And this is our way out of the pandemic.
It is the way out of a pandemic. Hey, we are celebrating a milestone here at at our health system. We have reached over 200,000 COVID-19 lab tests. That's a really big deal. These guys that we've introduced earlier are at the heart of that. So we wanted to talk for a moment about it, but this is literally the tip of the iceberg of the work performed by our lab, made up by more than 350 professionals, 25 departments, 7 days a week, around the clock. I've been through that lab. I had a tour of it earlier this week, or at the end of last week, I guess. Folks are so dedicated. They work so darn hard. The lab never rests, especially when you have 800 patients in your hospital. Right? You just never rest. Last year, that not ever rest resulted in 4.2 million lab tests being performed. That's crazy. So here to talk to us a little bit about testing are going to be, as I mentioned, Dr. Rachael Liesman, the director of the Microbiology and Path Lab, and Marissa Larson, a medical lab scientist. We're going to talk with them after we first see if there are any reporter questions today.
Good morning. Cody Holyoke, Channel 9.
Cody.
Hey, guys. So a couple things, and I know you'll talk about the need for testing, so I won't ask about that. But with Arrowhead's big mass vaccination event being canceled, for a number of reasons. They say logistics and scheduling, but also now the AP reporting about 3/4 of Kansas counties are turning down new shipments of the vaccine. I wanted to ask about hesitancy. And that might not be the only cause, but I know in some of the more rural counties, people are very hesitant still about putting something new into their bodies. I'm curious your thoughts and your concerns right now.
Cody, you're right there. You're directly on target, and we are concerned. And Cody, it's everywhere. It's not just rural counties. It's cities. I mean, yesterday we had 12,000 doses of vaccine for this week. We're gonna have extra vaccine. I think this is going to be hard, and we're just going to have to keep trying to go arm to arm and twist arms to get vaccines in arms. And how do we twist arms? And I do that in a proverbial sense. I think that it's going to come down to personal conversations, and I think this will be a very slow process. I think we've seen the rapid rush. We got over 50% of the country with the first shot. So let's assume 50% have been vaccinated. Pretty good data that a lot of people have had COVID. Now, there's probably a mix of those who have been vaccinated and haven't. But I think that's partly responsible for the slowdown in the number of cases. But there's still widespread community transmission. Without vaccination, if you've had COVID, your immunity will wane, and it will wane relatively rapidly unless you get another infection with SARS-CoV-2 and run all the risks from that are true. I think the things that will change the map now are, A, time, because I think as people get more comfortable with vaccination, then they'll see it and it'll be more successful. B, I think companies will start requiring vaccines once it's been fully approved by the FDA and maybe even before that. C, I think we will find ways, and we're working really hard at this and hope to pilot it very soon, of getting vaccine into our private medical offices so that patients will hear directly from the doctors. The most powerful advocate for vaccination is not, it's not LeBron James. It's not Patrick Mahomes. And I'm sorry to say anything bad about Patrick, because of course he's the best quarterback on the planet or in the universe. But the simple reality is the number one advocate is a person's primary care physician. We have to get those conversations really going between primary care and those who are hesitant. And one of the best ways to do it is park the vaccine in the primary care clinic. So when people say yes, you vaccinate them right there. And then I think success will beget success. And then we'll also start all the other media campaigns and discussion groups and all the people we've heard from, including the COVID Care Force yesterday and others. Those will be the things that slowly change this. But Hawkeye, it's still a worry.
Yeah, it certainly is. Again, I think, so we know that the Johnson & Johnson vaccine is on pause. We're not giving that. Right now, the only thing that is being given in the United States is the mRNA vaccines. And we've heard before, and we've continued to see now after 6 months, that the safety argument continues to be diminished because we know that these vaccines are safe. The mRNA is in your body for a very short amount of time. You produce the spike protein. You produce an extremely robust immune response to that spike protein. B cells, T cells, it protects you against a spectrum of disease. It protects you against a spectrum of disease for what we know, for the variants too, which we know are becoming more prevalent in the United States as well. So this is our way back to getting to do the things that we want to do. And we need to continue to give that message because it will protect you. And it will protect you even if you get exposed and get infected by SARS-CoV-2. It will overall protect you from that great spectrum of disease moving forward. And, we'll keep giving that message.
Other questions out there?
A quick follow-up on that.
You bet.
We talk about J&J, and I'm curious if the halt of this, even just the public perception of the mRNA vaccines, adds to some hesitancy. And also, J&J is a little easier to put into private medical offices than the other two because of the cold storage. I'm just curious about that.
Yeah, I think the J&J issues have clearly added to the hesitancy about vaccination overall. But what we hear is, gosh, see, we told you it was rushed. You didn't quite know what was going on. The reality is that the side effects of the J&J vaccine are so infrequent that it makes, we compared it to penicillin yesterday, right? If I told you the things that could happen with you with penicillin, you wouldn't take it. But everybody wants it. They want a Z-Pack. They want they want their antibiotic pills. Those are got so many more side effects than the J&J vaccine has. The J&J vaccine appears to be very safe. We'll know more tomorrow. I think there's going to be a big announcement about that. So let's stay tuned to that. But my guess is they're going to say it's really safe. It is true we want to have that one-shot regimen. It's also true the Moderna's temperature requirements are going to begin to moderate a little bit, and I think we're going to find ways to get the Moderna vaccine into clinics as well. So optimistic about that. But the second thing I would just say is I'm going to bet that in the long run, the one-shot data from Moderna and Pfizer looks about the same as the one-shot data from J&J, and that J&J is going to end up recommending 2 shots after the summer. But for right now, it is the only one-shot regimen, and I think that does make it particularly appealing. But it's bruised, right? It's bruised right now, and so I think we're going to have a harder time getting people convinced to do that. So my hope is that A, more data comes out to support it, B, that we begin to lower the cold storage requirements for Moderna, which makes it easier to get into primary care and specialty care offices, and C, more Americans will get it because their primary care physicians will turn to them and say, just as they do with the flu shot, can I give you that shot right now?
You know, in addition, I'm hoping that the pediatric studies are coming out, because right now the early data is that, yes, these are very safe for pediatrics, which we assume they would be. And that will also help in the overall population and leading to get to that point of population or herd immunity as well. So.
Other questions?
KCTV5 sent in a question. They read an article in USA Today yesterday in where Dr. Gregory Polland with Mayo Clinic, vaccinologist, we've had him on the program here. He was quoted as saying that eradication of the virus is off the table. Some other health experts are casting doubt on our ability to even reach herd immunity at this point. KCTV5 is asking, do you think that herd immunity is still possible?
Yeah, it's an interesting question. I think I read that article. I think what Dr. Pollan said was it's off the table right now because Americans aren't getting vaccinated. Yeah. And I think what he was really positing was, geez, if we can get people vaccinated, we could think about herd immunity. But right now, we're relying on widespread transmission of the disease plus vaccination. I'm not sure that's going to deliver us to herd immunity.
Yeah, and the combination of the hesitancy, all of that. So, you know, we do know there probably will be some level of coronavirus going around, you know, endemic within the United States, within the world, just because of how the other 4 common coronaviruses have been. You know, we know there's some level endemicity of MERS, which still occurs every year, but again, it's on the Saudi Arabian peninsula. But SARS, the first SARS, just kind of died out. I don't think that's going to happen. But we know that we can overall continue to be able to protect the health of the United States, protect our supply chains, protect our people that are our frontline and essential workers, keep our hospital capacity, you know, from things that we are seeing in Michigan, protect us from that if we continue to get vaccinated, and that is everybody, adults, and hopefully when the final data comes out, children as well. So.
All right, let's turn to our guests because we have a couple important questions for y'all. So take us back to this time last year, right? Tell us a little bit, Marissa and Dr. Liesman, tell us where you've come from and how did we get here?
Yeah, absolutely. I think this time last year, we had already been live. We knew we were going to need to ramp up. I looked back at the numbers. We were doing about 100 to 150 tests a day, which felt like a lot.
Yes, we were overwhelmed. Oh, my God.
Yeah, we were overwhelmed. You know, we had one machine doing it. We now have about a dozen machines, and we're running, I think our peak number over the last year was 1,400 tests in a single day. We passed our 200K milestone, which is exciting. Just for context, the group that's doing this work, their next highest test volume is actually 12,000 tests a year. So we introduced a massive amount of tests into this. In 2019, this group total in the year of everything they do did about 50,000 tests. So we've really put a lot on this group of people, and I think that they did an excellent job. It's great to pass this milestone this week, too. This week is Medical Laboratory Professionals Week.
Yeah.
So this is the week that we acknowledge and celebrate the work that is done in the laboratories. It's been nice this year to have a spotlight on the work that they do, not only with the testing for SARS-CoV-2, but in all of our other aspects of the lab that are integral to taking care of the patients in our hospital and hospitals across the nation. So happy to celebrate them. Happy to have Marissa here with us. She is our COVID queen. She is a supervisor of our new molecular microbiology section.
Holy cow,
that
that's a
we've
big deal.
established kind of to take what we've been doing the last year and really run with it to continue to be testing for SARS-CoV-2, but offer a lot more testing, to our patients and continue to provide really excellent patient care from the laboratory perspective.
Marissa, have you slept in the last year?
A little bit. Yeah, it's definitely been a whirlwind. We are really fortunate to have a great team come together to make this all happen. So I'm very, very humbled to be a part of it.
Well, you guys have just done great. Talk to us a little bit about your team. I mean, tell us a little bit. So how does this darn testing thing still work? Is it really fast? Is it slow? Is it still super accurate? What do you see?
So in regards to the team, we actually started with a very small team. There was only in doing our high throughput. Yeah, well, there's 5 people, and we had to triple that number so that we could sustain this capacity. But we have a variety of instruments. So we have some instruments that are able to do it a little bit faster, and then we have some instruments that are more focused on high throughput that take a little bit longer, but they allow us to be able to get to that 1,000, 1,200, 1,400 a day. So we have had a lot of time and energy put into being able to build this up. And like I said, we just had a really great team step up to the challenge and get us to where we are today.
That's a big deal. So now you talked about some of the biggest challenges and great rewards you're taking care of patients, but I bet that Dr. Zhang, the chair of pathology, Fred Plapp, one of our other pathologists over the lab, and Rick Holdry are listening right now when I'm going to ask this next question because I know what they're going to say. What's next for the lab, guys? What's next? And don't tell me it has to be space, because I know it has to be space. But beyond more space, what else is next for the lab?
Marissa's going on vacation next week, so I feel like what's next for the lab is we all just
we have to
take
survive a week. Marissa, who let you have a vacation? Whose idea was that?
Yeah, it's a good question. What's next for the lab? We've recruited and trained a lot of really awesome people. So we're going to continue to bring in new tests, right? So there's always things that we do a bit of and we send it out to other people because we can't do it here in-house for any number of reasons. And now we've got these people. We've got a lot of fun new instruments and machines to play with. So in the last probably since February, March or so, we've really been focused on where are we going to go next? What do we need to bring in-house? How can we, provide better care? So really just kind of thinking about that, where are we going to be a year from now? After maybe our volumes continue to go down, hopefully, as everyone gets vaccinated and we see lower level community transmission, less of a need for the level of testing that we've been doing over the last 13 months.
Jill, let's see what questions we have out there.
All right, Cheryl wants to know, is it okay to get a COVID test and vaccine on the same day? The test is required by work, but they also want us to get the vaccine as soon as possible.
Go do it. No worries. Anybody have a worry?
No, I have no worries with that.
I don't.
No worries. Do it.
Yeah, and I also wanted to mention Marissa and Dr. Liesman, they have been featured in national articles, including the New York Times. They're very humble, but they're leading the nation, so I just wanted to add that in,
Well,
too.
I'm just going to boast from it. Gosh darn it, we have done a great job with COVID, and part of the reason is these two people right here, because we've led the way on testing and being able to help others with their testing, so.
Glenn asked, the docs a few days ago said that they have thousands of vaccines in storage at the facility. How long do the vaccines remain good and valid when stored at facilities like KU Med?
Well, fortunately, we have some pretty strong deep freezers, just like storing it at the pharmacy or storing it over at the Moderna plant. We can store that stuff for approximately a very long time.
Yeah, we have, minus 80, minus 70 freezers for storage, and it doesn't take a lot of storage space to store a lot of vaccine doses or vials, so.
Some of the storage places are so cold. Remember those vaccine videos that you and I shot, or not vaccine, the mask videos that we shot? Those freezers are like a Hawaiian beach compared to the freezers where we store the vaccine. It's not a place where you and I want to go do a video.
So they've maintained their cold storage and supply, so there's not an issue with expiration or the vaccines going.
In fact, I'm pretty sure our camera equipment just freeze and lock right up. That'd be tough. Not even Scotty can beam us out of that one. Go ahead.
Cody, if you're still there, I see that you have a question for Dr. Liesman.
Hi. Yeah, I was just curious if, with all the talk of testing that we've had, if you've seen a drop in COVID testing, and I know that the doctors have often talked about the need for more testing, if you could highlight that.
Yeah.
We're doing probably about half of what we were doing when we were at our max. So when we were at our max, we were doing 1,000 to 1,200 a day generally. We're doing 400 to 600. We still maintain that capacity. We can still do 1,000 a day. So we are ready. Certainly, when there was concern about a fourth wave and we were all concerned about whether or not we were going to have more community transmission, the lab kind of maintains a level of readiness. But we have seen our volumes decrease pretty significantly.
And just to say, Hawkeye, I think that people are not getting tested as often. I think there may be a little less spread, because what's our testing positivity rate?
We're at about 2% right now across the board. But I will caveat that with the vast majority of patients that we are testing right now are asymptomatic screening. So we're doing a lot of pre-procedure screening still. We expect those patients to have very low positivity rates. We're doing a lot of testing for our nursing home partners out throughout the community. Those individuals are largely vaccinated. We expect those to have very low positivity rates. So I think we have probably a bit of an artificially low positivity rate based on who we are testing.
Do you know what it is out of people who are just going through our drive-through testing clinic?
I think that they're probably that's the bulk of our testing. I don't know those numbers off the top of my head, but they're going to be around that 2%, 2-3%.
Yeah. So it's interesting that it's lower positivity.
Yeah.
Even factoring that out, I bet our positivity, I think it's probably lower. So we may have less community transmission, or people who are sick are just not coming to get tested.
I think that's a big
What do you
point
think's going on with that?
I think there's part of COVID weariness there. They may just assume they have it and maybe are not getting tested unless they are told to for work or some other reason like that. That's a very good possibility.
Cody, do you have a follow-up?
No, I'm good. Thank you.
Thanks,
Okay.
Cody.
Sharon wants to know, do the quick antibody tests differentiate between the antibodies acquired from vaccine versus those acquired by actual infection from the virus?
Some of them do. So some of our antibody tests target that spike. And so if you had a natural infection or if you had an actual vaccination, you would expect to be positive for spike with your IgG antibodies. Other antibody tests that are available target the N protein, and so if you had an N positive, that is expected to be from a naturally acquired infection because the vaccination is not going to induce an immune response to N. So you can sort of tell the difference between, natural infection versus infection acquired by vaccination.
Marissa, with all this testing and things, what else do you think about all day long?
Oh, goodness, I don't know. I mean, now, during COVID, everything was dictated by COVID all day long. But now that our volumes have kind of dropped a little bit, we're kind of thinking about what's next, and what Dr. Liesman kind of touched on before is how do we continue to provide support to the community and to our patients and everything, and how can we just provide great quality care for them.
Yeah, I think that's a great point, and we continue to strive for that. Even if you don't have COVID, we're going to offer you the best darn care.
Sarah wants to know, my town is considering repealing their mask mandate tonight. I would like to hear what KU docs still think is best practice for this time in the pandemic. We are just south of Johnson County.
Yeah, so, I'm an old stick in the mud. Gosh darn it. I think until we have more people vaccinated, I'm a little nervous about repealing mask mandates, especially indoors. I think, if somebody came up to me and said, listen, we're not going to have mask mandates unless you're outdoors and in a really big crowd or close together, I think I could get along with that. Nice article in the New York Times today, and remember the COVID stuff is free and open to all, that describes the safety and the importance of masking outdoors. When is it? And it really isn't most stuff outdoors. It's only when you're going to be around the same person for more than a few minutes within 6 feet. Then you can still worry about it, but especially if you're within 3 feet. But I think that masking indoors, it's just very clear that the dynamics of viral transmission are much, 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 much worse inside than outside. And so if you're going to say to me, hey, we're not going to have a mask mandate outdoors, but we're going to have it indoors, I'd grimace, because I'd say, big crowds still should be masked outdoors. But I could get along with it. I think indoors, man, I am not there yet, Hawkeye.
No, the data overwhelmingly show that the things that reduce the spread of disease and thereby reduce illness, hospitalization, and overall deaths in a community is masking and distancing and doing those things. Also, those in a combination with individual things like contact tracing, because this question comes up as well. Contact tracing is very important as well. So all of these things contribute to helping reduce the spread of disease, reducing overall illness, reducing hospitalizations, and of course death in that community. We've seen this happen in Texas. We know that still some businesses are still requiring masks for people that come in, for their patrons that come in and do that. But overall, the overwhelming data show that masking and distancing continue to be the best practice to help stop the spread, and also, just keep individuals safe and healthy.
Everybody wants to be normal.
Yeah.
But here's the problem. We're really not normal yet. So if you try to be normal when you're not normal, things don't go as well. And one of my biggest fears is you'll see what's happening in Michigan and Pennsylvania, and that ain't normal. So I urge all people out there to be very thoughtful about not masking indoors, especially in restaurants and businesses. In your own home, Godspeed. But when you go out outdoors, you're in a public place, I think that's tough.
Okay, Peg and Stephen have questions about rapid testing. Peg's first part of the question is, what is the difference in the accuracy, rapid versus PCR? And then Stephen wants to know, why can't we get an accurate rapid test? He's gonna try to answer Peg's question. He goes, is it red tape?
No, I don't think it's red tape. So the first question was the difference in sensitivity or accuracy. We know most of our rapid tests look for antigen. So antigen is a protein. It's made by the virus. We're looking for that. Our PCRs are looking for the virus molecular material, so the RNA of the viruses. We know from both SARS-CoV-2 and other viruses that we look at, like influenza virus, that our antigen tests just are not as sensitive as our PCR tests. They just don't detect virus quite as well. Why can't we get a rapid test? I think that it's based on the biology of the organism and the limitations of how those tests are made. Antigen tests, historically and always, with the technology we have available, just are not as sensitive as a PCR test, based on the chemistry behind them and how the testing is developed. There are rapid PCR tests, so that is an option. They're a bit more expensive. They're not as available. They're a bit harder to produce. Those, I think, are close to equivalent to what we offer in the laboratory. But most of the rapid testing that you're going to get at a CVS or a Walgreens, that's targeting that antigen. And just by virtue of how the test is made, it's not going to be as sensitive.
Yeah, I think that's just science. And please correct me if I'm wrong, too. One of the key steps in the PCR is, even if you have a small amount of genomic material there, one of the key steps is you amplify that to increase it so that you can detect it. So.
Yep. So all the stuff that we're doing in the lab is going to start with this massive amplification process. So we can detect one or two single molecules of the nucleic acid, and then we make a ton of it, and then we go and we look for it, and it's easy to find. The antigen test, there's no amplification component of it, and so you have to start out with enough material for your test to detect, and that's challenging.
Marissa, have you ever had a COVID test? Have you ever had the PCR test, the brain biopsy?
On myself?
Yes.
I have not.
You haven't?
Mm-hmm.
Oh,
I have
Marissa,
not.
Rachel, we have to. Have you had one?
I have had nasopharyngeal swabs, but I have not been tested for COVID this entire pandemic.
Okay, here's the deal, guys.
Marissa and I just spend all of our time in the laboratory, so
Did you have to go anywhere?
we've never been symptomatic.
Okay, that's
all
true.
lab required.
I do know that you all got your mailing address switched to KU.
I'm
Okay.
quite proud of the fact that none of us have been symptomatic.
You should be proud.
We've done
One
pretty
more
well.
question.
Okay, one more question, but I'm going to kind of sneak one in. When you're doing your wrap-up and your final comments, can you answer what you have to study in college to do what you do?
Okay.
But the last question goes to Dr. Wilcox. He says, what is the prevalence of, I'm going to say blood clots instead of I can't say the word.
Thrombocytosis, yeah.
In the female population without the vaccine. He writes, I saw 1 to 2 a week in my office as an orthopedic surgeon when I was still practicing.
Yeah, the clots, I don't know the raw incidence, and I should know because I read the article recently, but I can't pull the stat out of my head. It's 6 and something. Do you remember the number?
Yeah, and Dr. Alt produced a slide about that as well. I think it's 7 to 14 per million a year, but again, again, I don't know if that's specifically for women or if that's the general population as well.
Okay, so we're going to pull this question out for tomorrow.
Okay.
And we'll answer it in the things. It's a great question. That way we can talk about the J&J vaccine. By then we may know more. And I don't think the press conference is until like 10 a.m. or something tomorrow. So we'll find out. But we'll try to answer that
And
question.
Dr. Alt's coming back on Monday or Tuesday, I think, maybe, after his ACIP meeting.
Yeah, that'll be good. So we'll know more about that. All right, hey, tomorrow, by the way, in case you haven't figured it out already, if you don't know our pattern very well, we're going to have Follow-Up Friday, Kids, COVID, Inflammatory Syndrome, and Vaccines. Dr. Barbara Pahood, the Research Director of Pediatric Infectious Disease at Children's Mercy, and the Clinical Associate Professor of Pediatrics at the KU School of Medicine. She is going to be back with us here in the studio. I don't think we've had her in the studio yet, so that'll be a big deal. So we'll be back with her. She'll be joining us tomorrow, and we're going to be answering all your COVID questions. Hopefully, Dr. Wild is healthy again by tomorrow. He's been homesick. Apparently, it turns out that kids can still transmit other colds to their parents. Who knew? Because he is COVID negative. But when you talk to him on the phone, well, actually, you don't talk to him because he has laryngitis. He can't talk. That turns out to be an exclusion for hosting a program like this.
He did say he felt good. He's gone running. He just doesn't have a voice.
He feels good. I talked to him last night. It was an interesting conversation. It was a little raspy. He kept coughing. I just don't think that's right in front of the mic.
Yeah.
Okay, Marissa, final thoughts for today.
Well, I think they had asked about what you have to do to be a medical laboratory scientist, right?
Yes.
So our education, it's a 4-year degree, and there's kind of 2 tracks that people take. Either they just go ahead and get their bachelor's degree in clinical laboratory science, or some people get a bachelor's in biology or chemistry or biochem. And then we all go through a clinical laboratory science program. And at the end of it, we're ready to sit for our boards, and then we have to take the boards, and we get ASCP certified.
Very careful, very cool, and it sounds like a lot of work. I guess you have to be pretty smart to do that.
It's very heavy in the math and science, so people that like that and they like problem solving and doing like puzzles and stuff, this tends to be a good option for them. And we kind of get to be, if you will, disease detectives.
Yeah, I like that. I like that description of disease detectives. Final thoughts, ma'am? Dr.
Get
Liesman?
vaccinated.
Get vaccinated.
And then I don't know if you want me to answer that as well. I have a bachelor's in biology, a PhD in microbiology, and fellowship training and board certification in medical microbiology. So, like these guys, I was in school for a long time before I came here to KU.
When did you actually get to join the workforce?
2017.
And how many years did you have to do to train to get to 2017?
He's trying to figure out how old you are. And
I am not trying to figure out
he wants to know how old you are when you got out of
is.
school. Yeah.
I'm the old guy.
How many years? 11 or 12, probably. I don't know.
Yeah.
I can't do the math right now, but a lot. Enough.
That's a lot.
That's a lot of college. That's fun.
Yeah, don't say that. Your wild hair starts sticking out. You haven't shaved today. You're going to say, what is this guy talking about?
I think, again, can't say it any better. Please get vaccinated. We have plenty of open slots for vaccination scheduled times to come in, get vaccinated. They are safe. We'll continue to be able to get back to normalcy, get back to doing the things that we want with these vaccines. They won't make you feel too bad, just a little bit of arm soreness, maybe some headache. But overall, much better than getting COVID, much better than getting that risk of going to the hospital, much better than getting the risk of those chronic long-haul symptoms as well. So continue to evaluate, ask those questions of those trusted people, and go get scheduled for vaccine.
And remember, this V means live long and prosper. And isn't that right? And when you do it like this, it means I've been vaccinated. Go get vaccinated too. We're back tomorrow. And remember, get vaccinated, and there's still no place like home. See you tomorrow.